So where are some of these current challenges? What are seen as some of the reasons for these current challenges? Now, they exist both on the supply side and on the demand side, and I want to talk a bit more about demand in a minute. But the current challenges on the supply side are varied. So some of them are about access and infrastructure. So if the challenge is about filling that 20% gap, there's been increasing recognition that the way to do that is sort of part and parcel of the development and spread of effective health systems. If you're essentially trying to deliver vaccines through primary healthcare systems, some of the problems in delivery are, in some areas, simply to do with the fact that you don't have health posts. It's too far for people to get to them. So a lot of work, vaccination and the arguments for it have been quite a big driver for some of the broader work to try and make sure that health systems in this tiered way and that primary healthcare is available to all. There have also been some challenges and some sort of policy push to try and expand coverage with some of these newer antigens, so that in addition to those standard ones in the EPI programme, the measles and the diphtheria, pertussis and tetanus and so on, over the last couple of decades, through scientific research and development and trials, we've now got vaccines available for a whole range of other diseases. Hepatitis, the various variants of meningitis, which are big problems to different degrees in different parts of the world. Pneumococcus, which causes pneumonia and also variants of meningitis, and is actually, in many African countries, a bigger killer than malaria, interestingly. And rotavirus, which is one of the causes of diarrheal diseases, which is, also major public health problems in many parts of the world. So these antigens have become available. Research has made them available. There are challenges, first of all, in terms of price, in terms of enabling governments, who are often responsible for these healthcare programs, to afford them, and also in actually developing variants that suit particular regions and populations. So, for instance, pneumococcus actually became available as a very effective vaccine in the US a couple of decades ago and is in the United States part of routine childhood immunisation programme. But it was only in about 2005 that a variant that suited West Africa, where it's a much bigger killer of children, became available. And that's because populations are different, bodies are different, epidemiology is different, and the variants of pneumococcus were not the same as those in the US. So there are a whole series of trials in Gambia, actually, which eventually produced a pneumococcal vaccine that did work in African settings. But then there was a huge fight because it had been developed by GlaxoSmithKline as a northern pharmaceutical company, and they weren't prepared to make it available free to the places where it was needed. After quite a lot of negotiation and input from Gavi, it eventually was rolled out, but it was an enormous fight. So it brings out both some of the scientific challenges, but the ways they link up with pricing and affordability. There are also some quite interesting challenges that have emerged as diseases become almost eradicated. And this has happened with polio. Now, as we've seen, polio has lessened a great deal and actually only exists in certain places. Yet the vaccine that is used for polio is a live vaccine, which means that in effect it's introducing polio into the body. Now, that polio virus gets excreted by a baby that's been vaccinated. There have also been cases where, for reasons of lack of care or lack of knowledge, actually people have caught polio from the vaccination. So you can actually get vaccine-induced disease and little mini epidemics that have popped up. So there's a lot of research. The field of vaccine research, vaccinology as it's often called, is enormous. It's happening in the public sector, it's happening in the private sector. And there are many, many journals and many departments. Developing a vaccine for a disease is a kind of holy grail, because if you can prevent it, you've kind of dealt with it, as it were. It's a big scientific enterprise, which has had some important recent successes. One of the relatively recent ones, I suppose, has been the human papillomavirus vaccine against one of the causes of cervical cancer, which is now given routinely in many parts of the world, I think not everywhere yet, to young girls at puberty. But there are some key diseases, and some of the really biggest problems, malaria and HIV, that have gone on being incredibly challenging because of the nature of the microbe and the interaction between the microbe and bodies. Both malaria parasites and the HIV virus are incredibly difficult to produce a vaccine for because they mutate, they move, they're constantly evolving and adapting. So the minute you've got a vaccine that you think works, the virus itself mutates and it's no longer effective. Malaria is quite interesting. I mean, the latest trials have found a vaccine that seems to be effective at about a 60% level in children, which is actually the highest trial success that there's been so far, but it's still not there. And then there's also quite a lot of research, which the Gates Foundation have been particularly behind in some of their grand challenges, about delivery technologies, particularly to meet some of the areas which are a bit more challenging. Now, if vaccines require injection and needles, you need people who are trained to give them. You also need to have sterile needles and a supply chain that makes sure that those are there, avoiding some of the horror stories of reuse of needles and non-sterile needles, which certainly happened in the early days. I mean, I remember when I was doing PhD fieldwork in Sierra Leone in the mid-80s, I used to walk around remote forest villages in Sierra Leone and Liberia with our local paramedic because it was a way to get to some of the more remote places, and being absolutely horrified that he would have a queue of mothers with their children and he would inject and inject and inject, and it was the same needle and over again. And my kind of gut instinct was, this is all a very bad plan, but I was just a student in those days, very little I could say. But this was a very, very resource-poor setting, and maintaining sterile needle technologies was difficult, and it's now become much easier, but it's another aspect of supply chain. You've got to have the sterile needles in their packs. And equally, keeping the cold chain and vaccines that need refrigeration also creates demands in resource-poor settings, that you've got to have fridges, you've got to have electricity to run them. And even despite advances in portable solar fridges that can be carried on motorbikes into remote rural areas, the challenge to develop vaccines that don't need refrigerating has obviously been a big one, which could make a real difference. These are also sort of research frontiers which are moving on. Okay, funding has been the really big challenge. There's a lot of interest in vaccine development, but actually it's proved very difficult to fund, partly because, as compared with curative drugs, which once somebody takes, they take over and over again, there's not very much profit in vaccines. They're given to everybody, but they're given once, or they're given in a kind of 1, 2, 3, and then that's that. So it's not like a person who gets heart disease and then has to be on heart disease medicines for years and years and years and years and years and spend lots of money on them. So vaccines are kind of unprofitable. And then there's also this problem that in many of the areas where they're needed, governments, and they're, as it were, a public health measure, governments have not been able to afford the newer antigens. So it hasn't been very profitable for pharmaceutical companies, for the private sector, to go into vaccine development. And so we had a period where actually all the innovation interest was biased very much more towards developing curative drugs, and particularly curative drugs for the diseases that afflicted the richest 10% of the world's population. But a lot of this began to change. The kind of move towards the Global Alliance on Vaccines and Immunisation and a whole range of other philanthropically funded and public-private partnership initiatives, which really began to emerge from around 2000, have been extremely important. So we've had IAVI, which is the International AIDS Vaccine Initiative. We've had the Global Fund to fight AIDS, TB and malaria, which has put a lot of effort into vaccine development, and the Gates Foundation, which has contributed to these and to its own Grand Challenge programmes, have helped to provide the funding, the upfront funding, to do things like providing advance market commitments, so to guarantee to buy up bulk supplies of vaccines and give them to the countries that need them. So, as it were, giving the advance payment and therefore the incentive to private companies to develop them. And also sort of innovation prizes have really helped. They've made an enormous difference. But they've also led to some further questions, because most of these initiatives and the programmes that they're founded on, whether it's about the vaccine development or the delivery programmes, are focused on particular diseases. And they're also focused very much on the technology itself. So people have begun to raise questions about, I mean, these are almost seeing the vaccine itself as a kind of silver bullet to deal with a disease. And people have raised very valid questions about whether that will actually draw attention away from some of the broader challenges about building up health systems. If you focus simply on the vaccine, is that giving you an overly technology-led and single disease focus? There have also been these questions about the focus on a vaccine and a single disease, and really connecting up with this bigger policy debate about the relationship between what are often called vertical, single disease-focused interventions in public health versus those that are horizontal, that are systemic, that are looking at a healthcare system and addressing and, as it were, putting in place the ability to deal with a range of healthcare challenges. And I think you'll come across this in the sessions around HIV and AIDS as well, whether, I mean, it overlaps with the vaccine debate, but has been very much a debate there about whether the enormous focus on HIV and the focusing of personnel and of health resources and infrastructure around AIDS has actually drawn away from and undermined other aspects of health systems. One of the challenges then, and as many people have argued, has been to ensure that the kind of funding which is coming through these public-private partnerships don't just go to the technology itself, but are also channeled through to health system strengthening. So moving on then to some of these questions. Okay, so there are some challenges around supply, getting vaccines out there. But as some of those come to be addressed, questions about demand actually become more significant. So I think we need to ask, and what I want now to do in the rest of this lecture, is to think about why it is that people sometimes fail to take up this apparently wonderful, universal, life-saving, disease-preventing technology, even when it's available, even when it's accessible, even when it's affordable. And this has become really the big current policy issue. Sort of, if you think about that graph again and filling that remaining 20% gap, some of it's about getting vaccines out to remote areas and making sure that vaccines are there in the clinics and that people have access to those clinics. But quite a lot of it's also about making sure that people are actually taking it up. So there's more policy attention in this area, and it's also one that then has to interlock with this long and really quite complicated history of people's anxieties about vaccination, their resistance to it, and indeed often the movements, the social movements, which have emerged both around particular vaccines, questioning them and critiquing them, and anti-vaccination in general. Okay, if one's to take the idea of vaccination demand, so there's a lot of discussion that sees healthcare interventions in terms of supply and demand. But I think we need to unpack demand a bit more. What are we really talking about when we think about demand? Well, I think we can really divide it into acceptance and non-demand. But if people accept an intervention like vaccination, why are they doing it? Well, social scientists and health workers who've unpacked some of this have differentiated a number of kinds of acceptance. It might be very passive. It might be simply that people are complying with an expectation or being indeed pressurised by health workers or by the state, or in some of those earlier campaigns by militarised agents, to accept this intervention. And whether that's acceptance or coercion, I think there's a very fine line. I think there have been some circumstances around vaccination where people have sometimes feared to refuse and been subject to abuse and to shaming and worse by health workers or campaigners if they've said no. So that's one kind of acceptance or coercion. But then there are these more accepting kinds of acceptance, and in the literature a distinction's been made between social demand and active demand. Now, social demand one can really see as based on a kind of rather general perception that somehow vaccination's a good thing to do. Go back to some of those posters about the relationship, the sort of equation between being a responsible parent and taking your child from vaccination. It's a social expectation, it's a norm. It's just something that you do. And I think also here come questions about a sort of general trust in biomedicine. But that's rather different from what in the literature is referred to as active demand, which would be really about people being informed, publics being informed about what vaccinations actually do, about the benefits of them, and also possibly the risks, as we'll come on to, and actually the need for specific vaccinations in kind of biomedical terms. So active demand is precisely what those posters with all the information about when you come and what the vaccinable diseases were about was trying to inculcate. And there's often a view in public health that actually what one wants to do is move from a sort of social demand to active demand. You want informed publics who know what they're about, they can make choices, they can come forward because they know the real benefits. And so a lot of education is geared towards kind of building active demand. And then there's something else, which was a phrase that my colleagues and I, in the work we did around vaccine anxieties, a phrase that we coined, because we saw something that was neither social demand nor active demand. It was people very much wanting vaccinations, in this case for their children, for very specific reasons which they could talk about, but they didn't fit with a kind of biomedical idea. They didn't fit with biomedical theories about how vaccines worked, and they didn't relate specific vaccines to specific diseases in the ways that this active demand discourse would assume. Rather, people had their own kind of culturally grounded, quite specific reasons for accepting particular vaccines. And so it was a slightly different category that was kind of between this and also came from a more sort of anthropological appreciation of how people understand diseases in their own terms, in particular cultural settings. So then what about non-demand? Now, there's a term that we came across a great deal in the Gambia amongst public health workers, and I've heard a lot in developing countries, not so much in the UK, I have to say. This idea of default. So if vaccination is something that everybody should do, if you don't do it, you're by definition a defaulter. It's almost a kind of pejorative discourse. It's people who are somehow doing wrong. They're not doing what they should be doing. And one often finds narratives and storylines about default and blame in the approaches of policymakers. You find them in the literature, and you often find them amongst frontline health workers, nurses, vaccinators, GPs, who will have their own explanations as to why people are defaulting on this apparently excellent, fantastic intervention. But again, I think we need to unpack default. And it might be to do with willingness, but actually inability to go for vaccination. Now, that might be because your clinic's too far away, or you've got other kids to look after, or there's no transport, or you've got too much other work to do, or other family members are ill, or there's some crisis. I mean, many settings where migration, movement, people displaced, uprooted, are not in a position to do something as routine and regular as sticking to an expected programme of immunisations. So lots and lots of reasons why people might want to but be unable to go. There's then situations where people refuse particular vaccinations, and that's really what we've got going on in the MMR case, but they might be perfectly happy to come forward for others. So they might have particular worries about MMR or HPV. But that's rather different from then a sort of third category, which in the literature is often thought about as resistant of anti-vaccinationism, which would question the need for vaccination at all. There are maybe many grounds, again, for doing that. It might be because vaccination links with theories of health that you don't agree with. There are populations actually in this country, and very many in Brighton, who don't go for biomedicine and actually prefer to turn to complementary and alternative therapies for a great many health problems. We found in doing the survey that we did for the vaccine anxiety study amongst parents in Brighton, about 10% of the sort of 2,000 plus parents that we interviewed had actually refused vaccinations altogether and took their children instead for homeopathic consultations. And there's a kind of rather strange homeopathic vaccine which people advertise. But there are health philosophies that are incompatible with vaccination, which can be bases for resistance. But other bases for resistance might lie in fundamental lack of trust in what people believe vaccination is doing, or a view that this might relate to anxieties about the nature of vaccines as a programme, or to lack of trust in the agencies that are delivering it, including in the state. What's quite important to recognise is that how demand and non-demand or default and the reasons for it are understood are pretty critical, because depending on how you understand those things, you would adopt very different policy strategies for either attempting to increase uptake or perhaps for saying actually increasing that uptake is not a good idea.